hijo
Gracias.
de, hijo de, hijo de ortopedista, que está en este momento con Jean en Toulouse. Entonces, pues realmente muchas gracias. Bienvenidos.
Gracias.
La idea a todos los miembros acá, primero darles las gracias a las personas que están conectadas, 28 colegas, agradecerles que tomen su tiempo hoy y estén con nosotros. Hoy estamos lanzando nuestra segunda edición de la revista, así es de que para nosotros es un motivo de orgullo poderla lanzar. De mi parte, un agradecimiento total a Paulo y al grupo del comité editor, como Gustavo, Nicole, a Camilo y a Laura. De verdad, muchas gracias por este esfuerzo. Y uno de los artículos que va a salir publicado, como ustedes lo ven, es el que va a mostrar Jean y Luis. Y quiero que Paulo sea la persona que nos presente esta segunda edición. Así es de que vamos a estar muy atentos en esta hora de este webinar que va a ser muy importante. So thank you so much for everybody. And Paulo, you are in charge.
Muchas gracias. Perdón un segundito. Eh, ¿se está viendo la pantalla o no?
¿No? Se está viendo tu computador ya. Ahí.
Ya, ahí ponla a rodar que ya se ve bien.
Ok. Este es nuestro logo. Como bien lo dijo Manuel, estamos encantados de poder hacer una pequeña presentación de no más de 3 o 4 minutos de este que es nuestro proyecto bandera, al que le hemos botado muchísima corriente y estamos realmente orgullosos de cómo se está desarrollando. Esta revista, Videoaccart, es la revista oficial de nuestra Asociación Colombiana de Cirugía Artroscópica y Reconstructiva. Es una revista pionera en publicaciones multimedia en español y nuestro objetivo fundamental y la misión que nos hemos propuesto es enviar videos de técnicas quirúrgicas que todos puedan entender, captar, aprender, pero no solamente desde el punto de vista de receptor de información, sino también de toda la posibilidad que hay de todos nuestros colegas latinoamericanos de poder publicar sus técnicas quirúrgicas. En Videoaccart creemos muy firmemente que esta fusión académica debe estar asociada con una presentación de altísima calidad, multimedia, que pueda ser vista las veces que uno quiera, que pueda ser replicada, de tal forma que el objetivo principal es mostrar técnicas del día a día o técnicas de avanzada en donde nosotros podamos mejorar nuestra práctica del día a día. Debo hacer un reconocimiento a todo el consejo editorial, un reconocimiento muy especial a nuestro médico asistencial, a la doctora Nicole Sedano, que está aquí con nosotros. A mi mano derecha, desde el punto de vista médico, que es el doctor Gustavo Gil, la secretaria ejecutiva Laura Pinilla y, por supuesto, nuestro director ejecutivo, que es nuestro presidente Manuel Mosquera. Este consejo editorial cada día se irá fortaleciendo más. Al principio uno no tiene la dimensión de dónde está, pero sin duda le vamos a poner tareas mucho más ambiciosas para que formen parte. Aquí hay un grupo muy especial de expresidentes y de personas que tienen reconocida trayectoria en el manejo de los videos. La primera edición fue un éxito, realmente podríamos mostrar una cantidad de estadísticas de las visualizaciones dentro de Colombia y fuera de Colombia, y estamos presentando ahorita con mucho orgullo la segunda edición. Miren ustedes lo que viene para nuestra segunda edición. El doctor Guillermo Nátera y el doctor Mosquera, trocloplastia, efectos de la artroplastia total reversa y de la posición y los torques musculares del deltoides en un análisis computacional de nada menos y nada más que el doctor Giovanni Di Giacomo, Jean Kany, con su técnica de DAS, con una modificación dinámica de una estabilización dinámica anterior modificada para incrementar el labrum glenoideo Y este va a ser la primera de los webinars que vamos a hacer con los autores de los videos para que nos los expliquen en vivo y en directo. Solamente déjenme mostrarle dos o tres presentaciones de de la nueva revista. En este caso es el doctor Giovanni Di Giacomo.
There are a number of surgical indications for reverse prosthesis.
Quiero que
The
por
procedure
favor
was
vean
originally developed
la
for
calidad
irreparable
de los videos,
non-functional cuff lesions.
que por supuesto están
Today, it is
revisadas
also
por pares
indicated for arthrosis
y han
and the
pasado
sequelae of fractures of the
la
proximal
estricta
third of the
evaluación
humerus,
de todo el
which have
comité
been
de las
treated both
revistas. Kany, voy a pasar a Kany relativamente rápido con su técnica de hanging biceps, porque nos las va a explicar. Esta es una técnica del doctor Gustavo Gil de reconstrucción de manguito rotador. El doctor Alejandro
Profesor doctor
Jaramillo
Alejandro
presentándonos
Jaramillo.
su técnica de
Para
reconstrucción
este
del
Videoaccart
ligamento
les quiero
cruzado
mostrar mi
posterior con
técnica de
técnica de
reconstrucción
monotúnel.
de un as para el ligamento cruzado posterior.
Trocloplastia por artroscopia del doctor Manuel Mosquera. Miren ustedes la calidad de los videos y realmente están en presentación en español y en inglés, de tal forma que tenemos la oportunidad de no solamente tener al público latinoamericano, sino que también al público angloparlante. Y para nuestro tercer volumen vendrá muy pronto nada menos que
The goal
el
of this
doctor Pascal
presentation is
Boileau,
to show a new
hablando
arthroscopic
de
guided latargy technique
step by
for
step
patients
de
with
la
anterior
cirugía de la
recurrent
tarjeta
instability.
artroscópico
The 5 required
en una
anterior portals are
presentación
shown here.
realmente
First, a
impecable de la
systematic
cual todos
inspection of
vamos a
the glenoidal
aprender
joint is
y
performed through
estoy
a
seguro
standard
que
posterior
podemos
portal.
tomar
The
tips
70-degree
de cómo mejorar
arthroscope is used
nuestra
for the entire case.
curva de aprendizaje en relación a esto. Y el doctor Giovanni Di Giacomo
In
nos ha enviado
anterior-inferior instability,
adicionalmente
in
una
addition to the
nueva
damage to soft
presentación
tissues, ACCART lesion,
biomecánica
it is
de cómo se
important to
comportan las
evaluate the
prótesis
bipolar
reversa y
bone
cómo son
lesions
los
known
nuevos
as
conceptos en
Hill-Sachs
relación a la
lesions
pérdida
and
ósea
glenoid
en
bone loss.
inestabilidad. De tal forma que este pequeño abrebocas no es más sino para invitarlos a que visiten nuestra página web. Aquí hay un QR para que nos visiten y puedan enviar todos sus videos. Y muchísimas gracias a Manuel por darnos la oportunidad de hacer esta presentación. Manuel.
Excelente. Aló.
Te oímos, Manuel.
No, extraordinario. Felicitaciones por esto, Paulo y el comité. Ya se viene la tercera edición, como ustedes dicen, esperamos hacerla en septiembre. A continuación, Paulo, pues quiero que presentes a Jean y a Luis y nos vamos ya con el temario, cómo lo vamos a trabajar, ¿ok?
Muy breve presentación, pero porque ya no necesita presentación en Colombia. You don't need it. Presentation in Colombia. You are the part of the home in your Colombian guy. Así que es un verdadero líder de opinión y hoy nos va a presentar su técnica modificada para la inestabilidad anterior. Creo que es una excelente técnica. Nosotros tenemos un grupo de colegas que están explorando esta posibilidad y aspiramos a tener una muy buena discusión. Y tengo el honor de presentar a Luis Alfredo Miranda, ortopedista mexicano del norte de México, que está en este momento rotando con el doctor Kany en Toulouse, France, y que nos va a dar la explicación en español para nuestros colegas de la técnica. Así que adelante, Jean, y después haremos una discusión lo más interesante que se pueda. Go ahead.
Okay. Thank you very much for your introduction, Paulo. I'm very happy to be here with you, and I am very proud to introduce you officially one of my best fellow ever, which is Luis Miranda. Alfredo que es de Mexico who is learning with me for 1 year. So, Paulo, do you see my slide?
Yes.
Yes, perfect.
Thank you very much. So this is a presentation of what I call the hanging biceps. It is in fact a modified technique of the dynamic anterior stabilization described by Alexandre Dederman and Philippe Collin. I have no conflict of interest for this presentation. So in shoulder instability, you have from one side, you have the lesions with labral tears, humeral head lesions, and gluing bone defects. And on the other side, you have a treatment option with ACCART, ACCART plus remplissage, and lethargy. Each of these techniques can be made today either open or arthroscopic. And the problem is we have to learn from our mistakes. And I can grant you that I've done a lot in my life. So the ACCART, as you know very well, the ACCART, there is many advantages because it is the first line treatment and procedure, but you have lots of drawbacks on my side. It can propose only in case of minimal glenoid defect. There is a high rate of recurrence, more than 10%. Sometimes you have residual pain, stiffness, and arthritis. If you look at the failure after a ACCART procedure in this meta-analysis, you can see with time we progress a lot. Before the 2000 years, it was 33% of failures. Now it is about 11%. But remember always that the rate of recurrence in case of bone block procedure will be always less than 3%. So this is one of the main problems of the ACCART. If you look at this paper from 2004 to 2006, the rate of recurrence of ACCART was 9%. You can imagine with time you will learn a lot and you will improve your technique. It's a mistake because from this publication from 2006 to 2009, with time, the rate of complication and failures is 13%. So with time, even you operate better your technique, you will have still the same recurrence. And this is a study from the French Orthopedic Society, Shoulder Society. I was the president a few years ago. And if you follow your patients 8 years, you will see that the rate of recurrence is not 13%, but the rate of recurrence is 25%. So definitively, there is a problem of recurrence with isolated ACCART procedure. So to prevent that, we've imagined with Wolf in 2008, the ACCART plus remplissage, and I call that the bipolar fixation. Everybody knows ACCART and remplissage, and it was a very important technique in 2010. And with a ACCART plus remplissage, you can improve in stability, and maybe you can operate patient with off-track lesions. But you have risk of having a limitation of external rotation. You may have recurrences, and I will show you why. And you can create posterior cuff chair when you do this remplissage because you feel the teres minor and infraspinatus into the notch, and in fact you can cut the muscle of the cuff with a suture bridge technique. So in 2009 and 2012, this was my indication. Look, in yellow, it was bipolar fixation. I believed a lot in this technique and I decreased my indication of lethargy. And up of 80% of my patients were treated by bipolar fixation. But look at the rate of recurrence with time after 1 year, after 2 years, after 4 years. Even with bipolar fixation, even if you do ACCART plus remplissage, you still have the same rate of recurrence, 12% for me, 4 years after the surgery. So it's not better than the ACCART, just the rate of recurrence is delayed from the isolated ACCART, but the results are not better. So for sure, you know lethargy. It was 1954, and Natarget, imagine the triple blocking effect. And Pat, which French surgeons, understood that. He described the bone block procedure. In the same time, you have the ligament effect stabilization. And finally, you have a sling effect. So it is a triple blocking effect. This is the Latarget procedure. And probably this is the reason why it works very well. So the Latarget has lots of advantages. More, you can propose it with lots of significant glenoid bone defect with few recurrences, less than 3%. But you have some drawbacks, and when you travel in the world, you always listen that. It's a challenging procedure. You can make a bone overhanging or overstuffing positioning. You may have graft resorptions, or you may have graft non-union. Yes, it's true. So this is reason why Philippe Collin and Alexander Lederman have imagined the dynamic anterior stabilization. They call this the DAS. And maybe you know that it is maybe in case of subcritical glenoid bone loss, and they fix this this transfer. We are going to describe this technique with an indifferent screw. But the very first paper was not from my friends. It was from China, and it was with a button system. It was 1 year before the official publication of my friend. And you can see it was with an inlay technique, and thanks to the classical button at the very past posterior part of the glenoid. And then a very important name was my friend Oleg Milenin from Russia, from Moscow, who immediately developed this technique because he thought, he believed in that, and developed this technique with a modification. And he thought that the only technique maybe was better with a rim augmentation. And he proposed 1 year later, with an head-and-immediate procedure, a combination between the homework effect with the DAS technique combined with head and immediate technique. So it is not a Latarget, but it is Latarget-like procedure. Yes. And finally, my friend Jose Carlos Garcia from Sao Paulo, if you imagine an equivalent technique, it was an inlay technique, but with an adjustable button. So everybody, you see, try to adapt, to adjust, to modify the technique, because probably maybe it's very new technique and we have to improve it, or maybe because we have some drawback with the original description. And this is from Portugal, Clara and Ana Catarina from Lisboa. Imagine a technique with anchors, an onlay technique with a double polytechnique. So lots of techniques. So why modify again the technique? Why did I imagine something else? This is the technique I will show you now. So it is the original technique, but it is an onlay technique, but with fixation with anchors. You can augment the technique. Finally, I don't like the inlay technique because you destroy the bone somewhere, and as the biceps is long enough, you can use it to rebuild your Bankart, your rim technique. So this is the technique at the end of the vision. This is the posterior view you are supposed to have. You can see the rim is rebuilt. This is my split. You can see the homework effect, and here with the superior view, the rim is reconstructed, rebuilt, and so you have the advantages of repairing the biceps, the rim. This is the homework effect outside of the shoulder. And now I will give a word to one of my best fellow, which is Luis Alfredo Miranda, who will explain you in Spanish the technique. Luis, you can speak now.
Ok, ya me escuchan, ¿verdad?
Yes, it's good, Luis, you can speak.
Ok,
Perfecto.
bueno, vamos a presentar la modificación de la estabilización anterior dinámica. un poco de lo que explicaba el doctor Kany. Hay mucha recurrencia y falla después de una reparación de ACCART y puede haber dolor después de una reparación de SLAP. Las reparaciones de SLAP, como también a veces no tienen buenos resultados y es mejor hacer una tenotomía. Y es por eso que nos hemos movido de matadores de bíceps a usadores de bíceps. Entonces colocamos al paciente en posición de silla de playa y con visión posterior hacemos una desinserción de la porción larga del bíceps. No es una tenotomía como tal, porque en la tenotomía desinsertamos el labrum también. Abrimos el intervalo rotador por un portal superolateral. Posteriormente, viendo desde adentro de la caja, se empieza a hacer el split del subescapular, con cuidado sin dañar al nervio axilar. Posteriormente, la fascia clavipectoral se diseca lateral al tendón conjunto y marcamos el punto de inserción de las anclas a las 5 y a las 3. Aquí se hace el portal inferolateral, lateral al tendón conjunto, a través del split del subescapular. Se aumenta el split y se inserta la primera ancla inferior a la 5, que sería la ancla de tracción. Posteriormente se hace un portal superomedial, se rescata una sutura por el split y se inserta el ancla a las 3. Segunda ancla. Posteriormente, después de rescatar las suturas, nos pasamos la visión hacia superolateral, una visión anterior. Y aquí estamos viendo a las arterias y venas circunflejas y estamos buscando la corredera bicipital distal al tendón del subescapular. No dañamos la interconexión de la polea del subescapular con el supraespinoso. Y aquí estamos disecando la porción larga del bíceps. Tenemos aquí los vasos circunflejos. Posteriormente veremos a las 3 hermanas yéndonos hacia proximal. Y después vamos a ver el intervalo rotador, visión inferolateral y el split del subescapular con la sutura que recuperamos. Volvemos a la porción larga del bíceps para terminarla de disecar de su corredera y se rescata junto con la sutura que pasa a través del split. Y en este momento exteriorizamos a la porción larga del bíceps. Y comenzamos con unos lazo loops de 2 a 3 centímetros distales al muñón proximal, con ayuda de esta pinza clever hook. Y después con una sutura libre realizamos el muñón para el ancla sin sutura. Okay. Regresamos la visión y el bíceps entra a través del split. Se rescata por encima del intervalo la porción proximal. Y aquí estamos viendo desde la visión superolateral, posterior, y realizamos los nudos de la primera ancla inferior, que es el ancla de tracción. Y en estos momentos ya podemos empezar a ver el efecto hamaca, también por la visión anterior. Sling effect. Aquí estamos empezando a limpiar la base de la coracoides, el espacio subcoracoideo, que será el sitio de inserción para el ancla proximal. Se prepara el lecho del hueso y se acomodan las suturas alrededor del bíceps para cerrar estas suturas en el ancla knotless, que va a dar el efecto colgante de la porción larga del bíceps. Después nos quedan las suturas del ancla del centro, del medio, que está a las 3, y se anudan abrazando a la porción larga del bíceps. Y podemos ver ya la visión final con el sling effect y la aumentación del labrum. Una visión superolateral, el efecto colgante con el labrum aumentado y el sling effect, es el efecto hamaca de una visión anterolateral. Muchas gracias.
Okay, thank you, Luis. So could you unshare? Yes, thank you. I will share again to start with a discussion. Oh, it was not this one. We were okay. This one, I think. See. Okay. Everybody knows the easy score, the age, the intensity of sport activity, hyperlaxity, heel sacs, or glenoid bone loss. It's a score out of 10. You should know that if the easy score is more than 6, the rate of recurrence, if you make an isolated Bankart repair, is 70%. And you could propose an isolated Bankart if the easy score is less than 3. But this situation is very rare because you have to imagine to have an easy score less than 3, you need an isolated rim lesion with no bone lesion after 20 years old with a patient who makes no traumatic sport. This is very rare, number one. Number two, I think with time we have underestimated the bone loss, both on the both sides, heel sacs and bony Bankart. And finally, you can imagine that you may have some plastic lesion of the capsule, or you may have Hagel lesions too. So this paper from Chugaya 20 years ago have shown that 50% of the bone loss were fragment types and 40% were just erosion type. That means 90% of the patients have a glenoid bone defect. And this is a CT scan. Look, you can imagine that the bone loss is very small. And you could say, okay, I will make a Bankart. I've done that. But if you make a bony reconstruction with a Gerber index, you can understand that this very small bone loss finally is a big bone loss, and the 2D CT scan is not useful, is not enough to assess the bone loss. So if you have a glenoid defect, the rate of recurrence is very high, 37%. So this is what we could see if you play golf. On the same way, heel sacs have been underestimated too. 67% after the first dislocation, and sometimes more at the very first dislocation, but close to 90% in recurrent dislocation. If you have a heel sacs lesion, the rate of recurrence is 31%. So don't propose any Bankart in that situation. And unfortunately, this is very frequent. This is a golf player can understand very well this problem. So if you want to sum up this first chapter, have a look. You have a glenoid bone defects in 90% of the cases. You have a glenoid humeral heel sacs lesion in close to 100% of the situations. That means, for me, less than 10% of the patients are eligible for an isolated arthroscopic Bankart. So finally, remember this Hagel lesion. What is Hagel lesion? Humeral avulsion of glenohumeral ligament. You think it's very rare, but with time, we find more and more Hagel lesions, and maybe we underestimate it. What is it exactly? You can have a look here. Look at this capsule here, totally detached from the humeral neck. And if you do a Bankart in that situation, for sure, you will increase the rate of recurrence because the lesion comes from the humeral neck, not from the glenoid neck, so glenoid defect. So why or when a DAS could be proposed? I would like to say could and not can, because it's a very new technique. So yes, no glenoid defect, why not? Associated slap lesion, yes, for sure. If you have a slap lesion and an instability without any glenoid defect, it's a very good idea to use the biceps. As Louis said, you use the biceps, but you don't kill the biceps. You use the biceps to augment the capsule, the rim. And in case of hyperlaxity, maybe this DAS could augment the power of a capsule. So it could be, I don't say it is, it could be a very good indication. But what are the contraindications? I think take care as soon as you have any bony defect. And today, nobody knows exactly the cutoff of this bony defect between the Bankart plus remplissage, or the Latarjet. So does have a place to game for the game, but we don't know exactly the limit. So of course, for sure, if you have no biceps, you cannot do this technique, and you have a subscap lesion. I think it's a bad idea to use this technique because you have to repair the subscap first. So for sure, you may have some advantages with the DAS. It could be easier, safe, and less invasive than the Latarjet. But I could not say DAS is an easy procedure because you have to go out of the box. For sure, you don't need any suicide portal, but you have to go out of the box. Okay. Increase the instability. It decreases the risk of dislocation. For sure, or scapular dyskinesia, you don't need any suicide portal like for the Latarjet. So you have lots of advantages like that, and you can use it. I think in the next 10 years, we will talk a lot of DAS, the indications, and the limits. But today, it's maybe too early to be sure about everything. The DAS could have some drawbacks. First of all, as you can see in the video, the diameter of the long head of the bicep is very small, smaller than the conjoint tendon, and maybe the homework effect is not as efficient than with the Latarjet. This could create some pain with the biceps, even if it has never been described today. It could create some pain. We don't know the limit regarding the bony defect. Is that possible in the bony defect? I'm not sure. We don't have any comparative study and follow-up for sure. And we cannot say there is no risk with the axial nerve because you do the split, and as soon as you do a split, you are very close to the axial nerve. So DAS is not so easy, and you have some things to take care about. So what is my evolution for the last 15 years now? I've made 462 bipolar fixation from 9 to 2020. 405 Latarjet, you can see what I've done. And you can see my evolution from 2009 to 2020 was arthroscopic Latarjet for quite every indication. And I have to confess that the DAS is a technique which I have a lot of interest with this technique because it could have some indication. And look at this paper of Philippe Moreau there. Finally, the small bone defect might be more relevant than we think, because in the very first millimeters of the defect, this creates the bigger defect of deepness. And maybe in small defect, the DAS could have good indication. But remember this picture, because this could explain a lot of failure after Bankart, or maybe DAS, and you can understand that the Latarjet has a very good indication in every indication, finally, even if there are small bone defects. So in conclusion, for sure, when you have no glenoid lesion, yes, you can make bipolar fixation. It is what I've done in the last 10 years. But now I have to confess I prefer the DAS. But I still I still follow the indication of Latarjet, and Latarjet for me still is 90% of indication, and for me DAS is a very good idea, another tool in the box, but we need proof with time, and I would like to say take care as soon as you have a bony defect, because maybe the DAS is not strong enough. So finally, Latarjet, Bankart plus remplissage, or DAS, yes, we have three tools in the box. We have to use it, but for me, Latarjet remains the main indication. Okay, thank you very much, my friends, and I stop sharing. I'm ready for discussion, my friend Paulo.
Thank you so much. Very, very interesting and very clear. The goal of this kind of webinar is to send messages for especially for the young surgeons. So I have some question, especially in the indication. So right now, arthroscopy Bankart repair is not good for you. You prefer that technique in cases of the bone loss is less than 5%, and the patient has a bad quality of the capsule. This is your indication right now, currently?
Yes, I'm happy because you just made a very nice sum up of my presentation. So I think it was clear. As you can understood, I definitively stopped the isolated Bankart procedure, number one. Number two, I can say I have less than 10% of indication of bipolar fixation, but since we have now the DAS, I switch my indication of bipolar fixation to the DAS because I think the DAS is more logical. But I did not talk about DAS plus remplissage, but maybe DAS plus remplissage could be a very good indication too. So I take care about indications, and I think Alexander Derman has more experience than me, but I know he presented in Nice his experience with some of recurrences, and he was a little disappointed in the recurrences, and I think the indication is the main problem. When I have some doubt, I do a Latarjet. So maybe we will have a place of a DAS in the 10 years. We have to discuss with in the world with experience of everybody, but maybe DAS plus remplissage could be a good idea.
Jane, we have a huge problem with the hyperlaxity patients because recurrences for the type of collagenous is very, very high. Do you think is this a good solution for this kind of patient?
So difficult for me to answer, but I will explain you my experience with hyperlaxity. When I was young, I did open capsular shift, and I was disappointed. Then I tried arthroscopic Bankart with 3, 5, and then 7 anchors on the anterior rib. The idea was to make a capsular shift for sure. I was disappointed with bad result. Then I imagine the circumferential capsular shift to make a capsular shift anterior and posterior to try to create some stiffness in the shoulder. I was disappointed too. And finally, I've understood that, yes, for sure, you take rubber here, elastic, you take it together, but it's still rubber. So it's just a thick rubber, but it's rubber. And with time, 2-3 years, you have a new distension because it's a problem of genetic. And then I confess, I tried the Latarjet for that. And the Latarjet is not, because I thought the Latarjet is a bone block. There is no elastic in the bone and maybe it should work. But even if Latarjet, I was disappointed because as there is no bone loss on the glenoid, you have a significant osteolysis of your bone block. And finally, you just have the screws and you have no bone. And you have a new dislocation over the screws, and even Latarjet is a bad indication for hyperlaxity. So this is today where I am, and I tried not to operate these patients because it doesn't work. But maybe the DAS, that I don't have experience, but maybe the DAS could be a good indication because this could reinforce the capsule, and because you make an addition, you make an augmentation. So the DAS, I think, could be an indication, and you can augment the capsule and augment the rim. So why not? Yes, but I have no experience of that.
Yo quisiera, Manuel, para los hispanoparlantes, que nos hicieras de las dos preguntas que le hemos hecho, el resumen acerca de las indicaciones actuales en español y si es una buena indicación para hiperlaxitud.
Sí, lo primero es que cada vez menos Bancar aislado, por decir nunca, y solamente usa el Bancar remplissage en ese 10% solamente de lesiones bipolares, ¿sí? Y encuentra un paso intermedio entre esto y el Latayer usando el DAS en casos específicamente donde no tienen mucha pérdida ósea, ¿cierto? No hay mayor defecto óseo. Y en la pregunta que le hiciste, pues él está de acuerdo, considera que puede tener un muy buen papel el DAS en los pacientes con hiperlaxitud, porque se trabaja la parte anterior con el sling, se recupera, se aumenta ¿cómo se llama? El bumper, así es de que es maravilloso. Yo quería hacer una pregunta, Paulo, a Jan. Jan, let me ask you something. When I see the first report of the technique, I mean the traditional DAS, always I ask how measure the tension of the biceps, and if that is important thing. But when I see your technique, I suppose that you resolve that problem because you do a special loop, I mean a turn when you fix in the first stitch, I imagine you tension or over tension the biceps. That is true?
I just tension. Yes, thank you for the question. I understand. Yes, the question of the tension is in the heart of a problem of a technique. But I question me a lot, and finally today I do not question at all about that. I just cut the biceps, and I just reroute the biceps. It's just the rerouting, and finally I cut on the top of the glenoid. I reroute through the split, and I fix again at the top of the glenoid. So it's exactly the anatomic situation, the physiological tension of the original biceps. But this bicep, thanks to this biceps, I augment the capsule, I make a homework effect, and I augment the rim. So the tension today is not a problem for me because I keep the biceps safe and anatomical before and after the tenotomy.
But if you do the original technique, you are going to have that problem because you can't see how tension needs the patient. This is my thought. You resolve it with your technique.
Yes, thank you. I think it's a good point. I did not imagine this technique about that, but yes, it could be an answer. I wanted to change the original technique because I don't like to make a tunnel into the glenoid. You are supposed to have a bony defect, and then you drill 4.5 millimeters into the glenoid. Then you put your biceps inside, but you don't know the exact length, which is efficient finally, and you have a problem of fixation. And you have to put a screw, an interference screw, with a possible problem with resorptions or something like that, cyst, and so on. I don't like to destroy the glenoid at the time where I need to make a reconstruction. So finally, Oleg Milin first, imagine that, but with a difficult and complicated technique. I've just modified and improved the technique of the Oleg Milinin from Moscow. It's just an improvement of the technique of Oleg Milinin, yes.
What about the rehab program? Because you don't talk about it. Is different this kind of rehab program when you do DAS instead of Latrogen? You move some?
It is. I agree with Alexandre Lederman when he says the best technique in the world for instability is Latarjet. and every other technique must have the same result and the same follow-up. And the lethargy, you make physio immediately after the surgery, and after 1 month, the patient is very happy. After 3 months, he's normal. It's very difficult to have the same result with a Bankart. And with a DAS, I cannot push my patient to do the same physio. I take care about my patient because we are just with anchors, not with screws. And I ask my patient for the first month, not physio, please, just personal pendular mobilization. And after 1 month, we will start with the real physio. So today, the physiotherapy with a DAS is more, is not as quick as for the lethargy. But maybe next year I will be very happy with DAS, and we are going to keep time to push it. But I take care about my physio after DAS.
We have two questions. One of them is from Dr. Alfredo Moreno. Is which method do you use to measure the bone loss, or just?
Which method? Maybe do you want Luis could answer in Spanish? Do you want me to answer in English or Luis in Spanish? You know,
Sí.
Luis.
Estaba a punto de contestar aquí que utilizamos el Gerber Index. El Gerber Index, aparte de darte una medición del ancho, te da una medición de la longitud. Entonces, es una medición en 2 dimensiones. El Gerber Index. Y también nos ayuda a no subestimar los defectos que con la técnica del Dr. Burkhardt solemos subestimar.
¿Cuál es el punto de corte en porcentaje?
Es 40%. Después de 40% ya es indicación de hacer un Latarjet, porque hay mucha tasa de recidivo.
Okay, do you have any experience with product therapy in patients with hyperlaxity?
Experience with hyperlaxity with what do you say, Paulo? Which?
Prolotherapy. This is this kind of therapy to put the dextrose hypermolar dextrose glucoside into the shoulder.
No, I don't know this technique. In hyperlaxity, no, I don't use dextrose into the shoulder. No, I have no experience. Do you have experience of that?
No. It's a question from the audience.
Oh, okay.
This is the SLIN effect is very, according with the Yamamoto's studies, the SLIN effect is very important in the maximal range of motion, and the bone block is very important to avoid instability in the mid range of motion. Okay, so we recreated the SLIN effect, just the SLIN effect. What about the middle range of motion?
The middle range of motion. The question is, do we have any stiffness after?
Yes.
Theoretically, if your bone block is well positioned, just flush to the joint, you don't have any stiffness. I understand your question. When I did open lethargy, I've never had any stiffness of my shoulder. In external rotation, open lethargy, okay? External rotation. When I start with arthroscopic one, all my shoulder was stiff in external rotation. So there was a technical problem. And I understood the problem a few years later. It was the quality of my split. Because when you open, you make a big split, it's very easy for show. And it's very easy to put your bone block. But when you do it arthroscopically, you are afraid to go very medial in your subscap. And if you don't make a very medial split, then for sure you don't have a good external rotation. But now with experience, I'm making very good split and large split, and I have no limitation of external rotation. So with a lethargy, you don't have any limitation of external rotation. No, this does not exist if your technique is good.
There is a question.
The question for the audience, Dr. Canal asked about what was put the biceps into the coracoids. Why?
I fix my biceps not into the coracoid but on the foot of the coracoid process.
Okay.
So I split my biceps, go through the split. I fix my biceps at 5 o'clock, then at 3 o'clock, and after at 1 o'clock. And 1 o'clock, you are into the foot of the coracoid process. I'm not onto the coracoid process. Okay. So I refix my biceps quite at the same position where I cut it just a few minutes ago. I fix it at the upper part of the glenoid at 1 o'clock.
Okay.
Jan, let me ask you something. Sometimes we have patients with instability and cuff tear, irreparable cuff tear, especially in old patients. Do you think this kind of surgery is gonna help us? I mean, 3-lat procedure is good option for that kind of patient, but what about this? Because you do the sling and you probably you have a dynamic effect, or you think this surgery is not work in that cases of massive tear?
So when you have a massive curve plus an instability
irreparable,
yes, elderly, for sure you have. I think there are two different patients. The one with instability plus supra and infraspinatus tear. So you can repair the cuff and you can do a DAS if you want because your subscap is normal. But there are other patients where you have a subscap tear. In most
sub is normal, but for instance, you have a supra and infra tear.
Yeah, so I think it's a good idea. Okay, you repair the cuff and you can put a DAS through the subscap. If the subscap is normal, you can make use of your biceps as an augmentation. Yes, it's a very good indication for that, for sure. Because when you do latargy in elderly, it's not very good because the bone is very weak. The screw doesn't have a good fixation, and you have to make a big split through the subscap, and you could damage your subscap. So in elderly, definitively, I think the DAS could be an excellent indication for sure. Yes.
Okay, thank you.
Another question from Nicolás Ochoa for you, Jan, is about the sling effect that has been reevaluated in some recent literature, giving more importance to the bone block procedure in more than 10% bone loss. And what is your perspective on this?
I know there is some debate regarding the sling effect. I know, but you have some paper who prove that it's not really useful. Other papers who shows biomechanics who show that it's very, very useful. So I have no answer about this. I don't want to criticize this paper, but for me, I cannot say I believe because it's stupid. I don't believe in anything, but if it does work, why not using that? I prefer to use the latargy because my bone block with a congenital tendon have a sling effect is very good. And I don't like to use head and binet procedure because you don't have a sling effect. And if it does work, why not? Regarding the DAS, the biceps is very small, but if you use the biceps to make your sling plus your ring augmentation, it should work. It should work, but maybe it doesn't work in case of significant bone loss. The problem is always the same. What is the limit of the indication? But I think the sling make for sure have some interest in biomechanics.
And the end, both techniques works because people like Ivan Won in London, in Canada, they do just put the butt block in the anterior part of the glenoid, and the outcomes are very, very, very nice. With this kind of techniques, is the other part of the range of the options is just a sling effect. What is the through in relation?
You see, in France, we have different bone blocks. We have a Latarget with a big bone block, as you know, but we have the Bristow, which is a very small piece of bone, very, very small, and both technique works very well. The only difference is not the size of the bone block, but the same Harmonic effect. So this technique works just because there is a Harmonic effect. The bone block in the Bristow is so small that you cannot say it's a bone block. So it's very difficult for me to answer, but I know the Hedeni-Binet procedure works very well too. For me, the advantage and the indication of the Hedeni-Binet is in case of Latarget failure of Latarget. Why not using Latarget? Because it's a bone block just close to the bone. You have a bone block, it's vascularized, and you have a conjoint tendon. So for me, it's the best indication and very easy to make. Everything is there. If it's a failure, or if the bone loss is so big that even the Latarget is not big enough, then you can use another graft. Why not? Knowing the fact that for sure you will not have any Harmonic effect. But as you know, the Americans prefer the iliac, the tibial graft.
Distal.
Yes, distal tibial graft, and they have very good results too. So maybe there is not the best technique, but for sure the easiest one is the local one because everything is there and it's not very expensive too. Iliac, so bone graft could be expensive too. So it depends what you want to do. For me, the Latarget is the main and first indication. In case of failure, I discuss something else. And the DAS will probably help me for very specific indication, hyperlaxity, maybe slap lesion, instability with slap lesion, but no bone loss. Yes, for sure, excellent indication. And as you told me, elderly with COFT, yes, this could be very good indication because the Latarget is not the best in this specific indication, for sure.
Great, great.
Dos anuncios importantes. El primero es que en la próxima edición de la revista Videoaccart, el doctor Pascal Boileau va a hablar de su técnica de Bristow artroscópico, de tal forma que allí vamos a poder discutir cuando lo invitemos si el tamaño del bone block es importante como efecto protector de la inestabilidad o si la combinación entre el efecto XLII y el efecto del bone block es lo más importante. Y lo segundo es que Jean Kany va a estar con nosotros en septiembre en Cali haciendo estas cirugías en vivo, así que están cordialmente invitados para el 12 y el 13 de septiembre en la ciudad de Cali en el curso de cirugía en vivo. Manuel, ¿alguna otra pregunta?
No, solo agradecer. Thank you so much, Jan. You always tremendous generosity to us. So thank you so much because this is Saturday. You are in vacation.
Thank you. It's a pleasure for me, my friend Manuel.
Yeah, Jan. So enjoy the summer, enjoy the beach, the sun. And Luis, gracias. Extraordinaria cirugía. Very nice. I'm sure we are going to start to do your surgery and see what happened with our result, okay? Very nice, very clever surgery, okay? Thank you so much, Jan. Paulo, gracias. A Camilo, a Laura, a Nicole, a Gustavo, a todos los colegas de ACCART, los invitamos a que miren nuestra revista y se animen a publicar, ¿ok? Miren las grandes figuras que estamos teniendo en nuestra revista. Así es de que, de verdad, esto es un proyecto, como lo dijo Paulo, muy importante para nuestra asociación. So, see you soon, Jan. Don't remember that Cali is the city of the salsa. So, yes, bring with you your good shoes to dance, okay?
Okay, I will come back with my shoes. Okay, no problem.
Gracias a todos. Feliz.
Salut, Paulo. Salut tout le monde. Merci,
Paulo.
Luis. Au revoir. Ciao, ciao.
Bye bye.
Gracias.
Hasta luego.
Gracias.
Gracias.
Muchas gracias por la invitación.
Chao, Luis. Chao. Gracias, hermano.